the NIHR machine learning and prediction modeling meetings that we run monthly here from the Biostats and the Statistics Health Department at King's College London. Today, we are very happy of having with us Dr. Huajie Jin, Lily, who's a senior lecturer in health economics at King's Health Economics here at Huajie University at KCL. Thanks, Lily, for being with us today. We are going to be hearing your talk. We're very interested in knowing more about whole disease modeling, and particularly on how you are using the type of models to inform the resource allocation decisions in schizophrenia services. So thanks very much. So welcome, and it's your turn when you are ready. Thank you.
Okay, thank you. I'll share my screen. Can you see my slides okay?
Yes, we can see it
Great.
perfectly.
Okay, I will make start. Good afternoon, everyone. It is my great pleasure to present this schizophrenia whole disease model that I developed during my PhD with my co-authors, including Professor Paul Templeton, James McCabe, Stuart Robinson, and Sarah Byford. Here's the presentation outline. In part 1, I will firstly discuss the motivations for me to develop a whole disease model for schizophrenia service. And then in the second part, I will briefly describe the methods that are used for developing the schizophrenia whole disease model. In the final part, I will share with you my personal reflections on the pros and cons of the whole disease modeling approach. Now let's start with part 1, motivations for developing a whole disease model. Before I joined King's, I used to work on the NICE clinical guidelines for 3.5 years. For those of you who are not familiar with NICE, NICE stands for National Institute for Health and Care Excellence. It is an independent organization in the UK, which is responsible for providing evidence-based guidance on a wide range of topics in health, public health, and social care. NICE clinical guidelines set out the care and service suitable for most people with a specific condition or need, for example, people with schizophrenia. The scope of a NICE clinical guideline is usually very broad and covers the entire care pathway, from disease prevention, case identification, assessment and diagnosis, treatment, including first line and subsequent lines, follow-up, and eventually end-of-life care. Based on the scope, the researchers on the NICE clinical guideline will then develop about 10 different research topics, each of which aim to address a specific decision question, which focus on a specific part of the entire care pathway. As economists, we usually don't have time to build economic models for all 10 topics of interest. So what we normally do is we will prioritize 1 to 2 research topics for economic analysis. So for the prioritized topics, we will conduct a systematic review of existing economic evaluations. And in addition to this, we will also develop a bespoke economic model. For those depriority topics, what we will do is we will only conduct systematic review of existing economic evaluations, but we won't build any bespoke economic model. So this is a current practice for health economists working on the NICE clinical guidelines. So what are the problems of the current approach? The first problem is imbalance in evidence availability. The second problem is inconsistent conclusions reported by different economic evaluations. And the third problem is ignorance of the interactions between different interventions. Now I'm going to explain these 3 problems one by one in more details. So the first problem is imbalance in evidence availability. So figure 2 shows the availability of economic evidence across different research topics of the NICE schizophrenia guideline. As we can see, of the 10 topics of interest, the health economist only find economic evidence for 2 of them. This means for the rest 8 topics, the guideline development group will have to make their recommendation without cost-effectiveness evidence. And then what about topics such as topics 3 and 4, where there is more than one economic evidence? Does this mean it will be much easier for the stakeholders to make their recommendations? Unfortunately, the answer might be no. That's because different studies might report different conclusions about the same interventions. A few years ago, my colleagues and we conducted a systematic review of economic models which compare the cost effectiveness of different antipsychotics for people with schizophrenia. We identified 52 models in total, of which 43 report that they have potential conflicts of interest, which means they are either kind of sponsored by a commercial company or the main authors is affiliated with a commercial company. 9 studies did not report potential conflict of interest. So we firstly had a look at the conclusion reported by those 43 economic models with potential conflicts of interest. And we find that all of them reported positive findings for the antipsychotic manufactured by the sponsoring commercial company. So this indicates that there is a possibility that the conclusion of those economic evaluations were influenced by the sponsor company. So what about those 9 studies which did not report potential conflict of interest? Unfortunately, these 9 studies also report inconsistent conclusions. Of these 9 studies, 4 of them reported that olanzapine is more cost-effective than risperidone, while the other 5 studies reported that risperidone is more cost-effective than olanzapine. Even if we further stratify those 9 studies by patients' health status, the inconsistency of conclusion remains. So why those economic models come up with different conclusions about the same intervention? That might be because those economic analyses were based on different model structure, using different modeling methods, and use different sets of input data. The third problem of the current economic model is they might ignore the interactions between different interventions. So this figure shows a complete care pathway for a disease. And there are interactions between different parts of those care pathway. For example, the cost effectiveness of a first-line antipsychotic treatment or subsequent-line antipsychotic treatment might depend on the cost effectiveness of early identification and intervention. That's because there is evidence showing that for those people who received early intervention service, while they're still at high-risk status, they're likely to have a better response to antipsychotic treatment when they do become psychosis. And on the other side, the cost effectiveness of a prevention program might also depend on the cost effectiveness of the treatment. For example, if we imagine one day there are some researchers at the IOPPM, they invented an amazing antipsychotic which can completely cure schizophrenia at very low cost, then what might be the impacts on those prevention program? That might mean that some expensive prevention program might no longer become cost effective because it becomes so cheap to treat schizophrenia. So that's why we are modeling the cost effectiveness of one intervention, it's very important for us to consider the interaction between the intervention and the rest of the care pathway. Due to resource constraints, most of the existing economic models are piecewise model, which means they only look at a small proportion of the entire care pathway. By doing this, they won't be able to capture the interactions between different interventions. So during the last year, while I was working on the NICE clinical guideline, I saw a paper which is about a methodological framework of whole disease modeling, written by Professor Paul Templeton and his colleagues from University of Sheffield. So to put it in a simple way, a whole disease model is a big model which covers the entire care pathway of a given disease within one single model. By doing this, a whole disease model will be able to provide comprehensive economic evidence across the entire care pathway, avoid inconsistencies, and capture the interactions between different interventions. So the methodological framework paper that I just showed you was developed for cancer, but I think that framework can be adapted to mental health problems as well. So that's why I'd be interested in developing a whole disease model for schizophrenia service in the UK. So that's my motivations. Now I'm going to move on to the second part, which is about the methods for developing the schizophrenia whole disease model. So the first step for me was to recruit stakeholders. I recruited 13 multidisciplinary stakeholders with different background, including healthcare professionals, researchers, commissioners, and service users. And then the second step is to conceptualize and construct the model structure. The conceptual models were developed based on clinical guidelines, auditing data, published literature, and expert opinion. Then I implement the designed conceptual model using a modeling method called discrete event simulation, abbreviated as DES. So basically, DES is an individual patient level model, which allows us to capture patient heterogeneity. The third step is to identify and prepare input data. I thought about using individual input data from the CRIS database. However, eventually, I decided to give up this idea, at least for my PhD, because at that time, I already come across a lot of technical challenges just by building the schizophrenia whole disease model. So I decided that I don't have any more time to spend on identify the right patient level data from CRIS. So instead, I use input data reported by published literature, such as systematic reviews, clinical trials, costing and quality of life studies. Where there is lack of evidence for specific input data, I use expert opinion to estimate a range of possible data. The final step is model verification and validation. I did comprehensive self-check of the model by myself. In addition, the overall model logic was checked by a second modeler. I also checked the outputs of my model with stakeholders and comparing results with published literature. The figure 2 shows the structure of the conceptual model. This conceptual model is very big, so I won't have time to go through the entire model in details. But basically, this model covers 4 modules. Patients enter into the model by Module A, Specialist Assessment Pathway. So people with possible psychotic symptoms, they will receive a special assessment in Module A. And then, based on the results of the assessment, patients will be triaged to different modules. For those patients assessed as clinical high risk of psychosis, they will be moved to Module B, clinical high risk pathway, where those patients will receive interventions such as CBT and monitoring. And then for patients who are assessed as first episode psychosis, they will be diverted to Module C, the psychosis pathway, where they will receive interventions such as antipsychotics, family interventions. For patients assessed as not at risk of psychosis, they will be moved on to Module D, out of scope and the death pathway. There can be transitions between different modules. For example, for people with clinical high risk in Module B, if later on they develop psychosis, then they will firstly move back to Module A to receive another specialist assessment, and then move on to Module C, the psychosis pathway. So for people in Module C, the psychosis pathway, if later on they receive a non-schizophrenia diagnosis, such as bipolar disorder or depression, then they will be moved to Module D, out of scope and the death pathway. So for patients who died in Module A, B, or C, they will also be moved on to Module D. So that's a conceptual model. Based on this conceptual model, I then develop a discrete event simulation model using a software called Simulate. So figure 3 shows you the developed model. As you can see, this model is consisted of many of these small blue boxes. Each of those small blue boxes, they stand for a work center. A work center can be used to perform some sort of transformation for the patients. For example, the work center can be used to update patients' health conditions, their health status, patient's age, patient's disease history, or patient's use of treatment. A work center can also be used to determine a patient's subsequent journey within the model, or in another way, which is the next work center that the patient will be moving to. Box 1 shows you examples of codes that I wrote for the schizophrenia whole disease model. So basically, behind each of those blue boxes that you just see, there will be kind of a many lines of codes like this. I'm not expecting you to read this codes during this seminar. The reason why I want to show this to you is just to give you a taste of what the real model looks like. So my entire schizophrenia whole disease model has over 6,000 lines of codes. And I did a quick summary. About 31% of those codes were used for debugging purpose, while about 69% were used for implementing the functions that I designed. Okay, now I'm going to move on to the final part of my presentation, which is my personal reflections on the pros and cons of the whole disease modeling approach. The first advantage of whole disease model is it can be used to assess more decision problems simultaneously and consistently. Table 2 shows the results of the cost-effectiveness analysis that I conducted using my schizophrenia whole disease model. So I used my whole disease model to address 5 different research topics, which cover 19 different interventions. While a traditional piecewise model can only be used to address one single decision question and covering a few numbers of interventions. And And also because my whole disease model was developed on the same platform and the same set of input data. So all the results of coming out from my model will be consistent. The second advantage of my whole disease model is it can capture interaction between different interactions. Between different interventions. For example, if we assume that the 5 topics that I present in the table just then, it covers the entire care pathway for schizophrenia service. And those A1, A2, B1, B2, these are the interventions covered by each topics. Say, for example, if we want to compare the cost effectiveness of intervention A1 with A2, and using a traditional piecewise modeling approach, what we need to do is we need to firstly make assumption about the current practice, or in other words, the current care pathway. For example, we might assume that the current pathway is consisted of B2, C3, D2, and E3. And then based on the current pathway, we come to a conclusion, say whether A1 or A2 is most cost-effective. Some people might argue that the traditional piecewise model are very small, so they don't cover the entire care pathway. However, the fact that they don't cover the entire care pathway doesn't mean they don't make assumptions about the existing care pathway. And the problem for this is, normally it's very difficult for us to decide what is the current pathway. For example, the current pathway for topic C could be a mix of C1 to C7 instead of a single intervention. What's more, the current practice might not be the most cost-effective intervention. For example, even if we assume that C3 is a current practice, but C3 might not be the most cost-effective intervention. So maybe a few years later, when NICE find out C1 is actually more cost-effective, then this will change the current practice. And as a result, the conclusion for topic A might be changed as well. The benefit of using a whole disease model is we can use the model to test all possible combinations of interventions across different topics. So by doing this, we don't have to worry about what is a current pathway and whether the current pathway will be changed in the next year. And some people might be wondering, is it that important to capture the interactions between different interventions? Say, for example, if I change the current practice from C3 to C1, will this actually change the conclusion for the other topics? So one of the interesting findings from my schizophrenia whole disease model is that changes to existing system configuration altered the conclusion for 2 out of the 5 topics. So this shows the current pathway that I assumed based on the clinical guidelines and expert opinion. So based on the current care pathway, I firstly run my whole disease model for each individual topic and work out the most cost-effective intervention for each topic. And then I find that for 2 topics, the current intervention is not the most cost-effective intervention. For example, for topic C, which is about choice of first-line antipsychotic for people with first episode psychosis. The current practice is patients are using a mix of different antipsychotics. So the conclusion of my model shows that, based on the existing evidence, amisulpride is the most cost-effective antipsychotic. This is for topic C. And for topic E, that is about the choice of antipsychotic for people with treatment-resistant schizophrenia. The current practice is patients with treatment-resistant schizophrenia will be prescribed with clozapine. However, there is about 4 years delay for patients to get clozapine. My model shows that the most cost-effective option for topic E is that patients with treatment-resistant schizophrenia should get clozapine with no delay. Okay, so what I did then is I then tried to replace the current pathway for topic C by amisulpride. And then I rerun my model for the rest of the topics. And what I found that this change in topic C lead to a change of conclusion for topic D. So for topic D, the most cost-effective intervention used to be antipsychotic plus family intervention. However, once I change the intervention for topic C to amisulpride, the most cost-effective intervention for topic D become antipsychotic alone. So I also try to change the intervention for topic E by replacing clozapine with 4 years delay with clozapine with no delay. And I find that this change leads to change of conclusion for topic C. So when we provide clozapine to patients with treatment-resistant schizophrenia with no delay, the most cost-effective first-line antipsychotic for people with first episode psychosis become olanzapine. So by doing this, we can demonstrate that the importance of capturing the interactions between different interventions across the care pathway. The second advantage of schizophrenia whole model is it can be adapted and reused when better quality of evidence become available. I'd love to reuse my schizophrenia whole model in the future. However, I've been so busy with lots of projects, so haven't got a chance to do so. But in the future, with the right project, I will try to adapt my schizophrenia model and try to use real-world individual patient level data to populate the model. That's all the benefits of using the whole model. So what are the problems of using schizophrenia whole model? The first problem is it requires a significant initial investment of time and resources. Overall, it took me about 12 months full-time equivalent to design and build the schizophrenia whole disease model. And one thing I want to mention is that when I started developing schizophrenia whole disease model, I already have like more than 3 years experience of developing model. Another problem is computational burden. Table 4 shows the computational hours required to run a probabilistic sensitivity analysis, the so-called PSA, on the schizophrenia whole disease model. For those of you who are not familiar with PSA, so basically it's just a type of sensitivity analysis which involves running the model multiple times using different sets of input data, so to test the impact of joint uncertainty of the input data. So in this table, each row shows the number of patients we include in each model run, while each column shows the number of PSA runs. Or in another word, how many times do we want to repeat the model runs? Those cells in green means the computational hours is within 2 weeks. So those cells in red means the computational hours is within 2 to 4 weeks. Those cells in yellow means the computational hours exceed 4 weeks. So as we can see, if we want to include at least 20,000 patients in one model run, and we want to run 100 PSA, that will take 7 hours to do it. And if we want to increase the PSA runs to 1,000, that would increase the computational hours to through 67 hours. And also, just to let you know, there is no gold standard in terms of how many PSA run is required. It will depend on the specific decision question and also about the level of uncertainty of input data. But most economic evaluation would use 5,000 runs as a minimum. So if we want to increase the number of patients to 200,000 and do 1,000 PSA runs, that would take us about 4 weeks to do the PSA. So there are some ways to accelerate the model running. For example, the most easy way would be to use multiple computers to run the analysis at the same time. During my PhD, I used 9 computers to run all analyses for my PhD. So I've been borrowing computers from my colleagues. And the third problem of whole disease modeling approach is it may be at greater risk of errors and mistakes. So all economic models are at risk of errors and mistakes. And because a whole disease model has a broader scope than traditional piecewise model, and it also has a more complex care pathway. So a whole disease model may be at greater risk of errors or mistakes compared to a small piecewise model. And what makes things worse is where errors are spotted, this may result in the need to rerun all analysis, potentially multiple times. So I will give you an example of my PhD again. Initially, I plan to finish all my analysis within 1 month. But then halfway through my model running, I found that there's a bug in my model. So I had to stop all my models, and which means all the results I saved are wasted. They're not useful at all. And then I started running the model again. And then later on, I found another bug. So eventually, I had to run my PSA 3 times, and it took me 3 months to finish all analysis. Okay, on my final slide, I just want to summarize the pros and cons of the whole disease modeling approach that I just mentioned to you. The advantages of using the whole disease modeling approach are, firstly, it can assess more decision problems simultaneously and consistently. Secondly, it can be used to capture the interactions between different interventions. Thirdly, it can be adapted and reused to incorporate new evidence or answer new decision questions, and hopefully can save some time and resources. The problems of using whole disease model is, firstly, it requires a significant initial investment of time and resources to develop the model. The second problem is computational burden. The third problem is it may be at greater risk of errors and mistakes. Where errors are spotted, this can result in the need to rerun all analysis, potentially multiple times. Okay, this is the end of my presentation. I'm going to stop sharing. Now I'm happy to answer any questions that you may have.
Thanks very much, Lily, for this